Thank you all for your patience. Good morning, good afternoon, and good evening. It is with great pleasure that I welcome you all here today for this webinar entitled Photoacoustic Tomography Detects Response and Resistance to Bevacizumab in Breast Cancer Mouse Models. I'm Jenny Martin Kruger, the Marketing Associate at Ithera Medical, and I will be moderating this session. The webinar itself will last for approximately 30 to 35 minutes, and we really do encourage questions. If you maximize the Go-To tool, you can see a question box where you can enter your question, and we will answer them at the end. The webinar will also be recorded for our YouTube channel, and we will send you a link to the recording over the next few days. Our speaker today is Dr. Isabel Quiros Gonzalez. Since 2018, Dr. Quiros Gonzalez is the head of a small pathology core in the Oncology Institute of the University of Oviedo. Dr. Quiros Gonzalez is actively engaged in her own research, but spends much of her time advising others. She completed her PhD at the University of Oviedo in 2011 and conducted postdoctoral research at the University of Cambridge, spending more than 3 years in the lab of Dr. Sarah Boendijk, where the focus was on optoacoustic imaging. It is on the basis of this work that Dr. Quiros Gonzalez will present her work here today, which was published in April of this year in Cancer Research. Over to you, Dr. Quiros Gonzalez.
Hi, Jenny. Thank you very much, and hello, everyone. So thank you, Ithera, for allowing me to share our research using optoacoustic tomography to study first the main characteristics of breast cancer xenograft mouse models, and then the response to bevacizumab treatment. So if it works, yes, it works. So first, I'm going to give you a brief introduction about breast cancer, the importance of hypoxia and vasculature in breast cancer, and a little bit of detail about our experimental design using MSOT imaging. So generally speaking, the first classification that we can do of breast cancer is the histological one, is the oldest of all, and is based on the histological characteristics, the similarities that the tumor cells present regarding the two main types of the breast. So as you may know, breast is formed by a variety of tissues, but if we are only looking at the glandular one, we have two kinds of cells. The luminal cell, that is the one that when it's due, it will produce and secrete the milk, and the basal, that is the stem cell of the gland. So based on these similarities and the degree of differentiation, the first classification was done. So we had ductal carcinoma that could be in situ or invasive, and lobular carcinoma that could be in situ or invasive. But then this very basic, very valuable, but very basic classification was giving very different results. So when you were treating the patients, two patients with the same kind of carcinoma, breast carcinoma, depending on depending on these histological subtypes, were given a very different response. So digging, and with the advances of the technology, several improvements were done. So first, immunohistochemical analysis, and they allowed to describe the three main receptors that are involved in prostate cancer response: estrogen receptor, prolactin, and HER2. And then a very remarkable advance in the development of breast cancer diagnosis, that was the PAM50 transcriptome analysis. And by crossing all these different disciplines, including the clinical information and the stratification of the age and heredity characteristics. Everything came up with 6 different types of adenocarcinomas that still were not answering the heterogeneity that we could observe in treatment response. I'm sorry again. So very, very lately, last year, we could have an additional level of complexity, adding copy number alterations and aberrations to these 6 classification stage. So this can give you a flavor of how, without any other consideration, breast cancer is very, very heterogeneous. But on top of that, we can, of course, add the response of the tumor microenvironment. So on this scenario, what we can say is that hypoxia alters dramatically several levels of the tumor microenvironment. So, of course, the vasculature, but also the fibrosis and the immune response in breast cancer. So it's already quite well established that tumors that are showing high levels of hypoxia markers have worse response to therapy and a shorter survival. In this example is metastasis-free survival, but we have several examples of this. And also regarding only vasculature and angiogenesis, that angiogenesis is a process closely regulated by hypoxia. We could see that those tumors that have, or better, those patients that have higher circulating levels of VEGF, that is a cytokine that induces angiogenesis and is regulated by an increase in hypoxia in the tumor. Those patients that were having lower levels of VEGF had better prognosis, both in relapse-free survival or in overall survival. So with all this scenario, one of the first targets that were developed against angiogenesis was the monoclonal antibody bevacizumab. Bevacizumab is an antibody against VEGF-A that the first research works were postulating as the main VEGF isotype that was inducing angiogenesis in tumors. As you see, there are several isoforms of VEGF, and not all take part in the same processes. So hypothetically, by inhibiting VEGF-A, we were able to block angiogenesis, and after this starting point in which the tumor grows, when the hypoxia starts, if the tumor doesn't have the ability to sprout new blood vessels, hypothetically it would die. If you block this process, hypothetically the tumor, it would die, and everything should have worked okay. But of course, this is science and it doesn't work okay. So the first studies were showing very, very promising results. But when the clinical trials were over fairly big cohorts, for example, 200 people, we could see that there was no benefit in overall survival, and that it was giving significantly difference in progression-free survival, but that eventually all the patients would show resistance to the anti-angiogenic therapy. It's important that anti-angiogenic therapy, it's always a coadjuvant therapy together with other more traditional kind of chemotherapy. And the problem was that the side effects were quite important. So as you see, this is a summary of the main ones, and some of them, they have quite high incidence, 15%, 7%, 7%, 18%. and some of them were lethal. For example, several cases of thromboembolism and hemorrhagic event were fatal hemorrhagic events, for example. So it did end up that overall FDA in the United States considered that the overall benefit of bevacizumab was not enough to overcome the important deleterious effect that the treatment had. But the feeling was always that if we could detect those ones that would respond, then it would be worth using bevacizumab for breast cancer. So we wanted to define like a good reporter of bevacizumab activity, and we used optoacoustic imaging. As you know, there are several contrast agents that you can use, exogenous ones. Some of them, they are useful for study vasculature, for example, the ICG, but we focus on an endogenous contrast, that is hemoglobin. This, as probably you know, it has hemoglobin has two different conformations depending on if it is oxygenated or deoxygenated, and a multispectral optoacoustic tomography can detect those. So our aim was to detect the total amount of hemoglobin as a measurement of number of blood vessels, let's say, and the oxygen saturation based on these two different properties of or spectra of hemoglobin with this technique. So this is the equipment that we use. I know that there is a new generation almost there or already there, I'm not sure. So we use this was a wonderful equipment, I have to say. Very solid, very robust, the Envision 256. We use, of course, as is recommended, but it's important to say this, isoflurane, so the animals were breathing the anesthetic. And we were obtaining the profiles of oxy and deoxyhemoglobin. We were taking the spectra between 600 and 950. One thing that was, I think it's important of our experimental design was that we were taking several sections along the caudal axis. So I wanted to have the whole tumor together, although as you will see, I didn't use all this information. So I was taking around 1.5 centimeter because I always wanted to have first an anatomical reference that was always the same, this one that I'm showing here. So I was using as a reference of the oxygenation, the aorta and cava veins, and the aorta and the cava vein. So by measuring this one, I was taking the healthy, so the normal tissue levels of total hemoglobin and oxygen saturation. And it was always before the branching that these two vessels have to the iliac bone and to the spinal cord. For example, once I had this located, I did several measurements along different time points. So I want to be very solid on the location. So I was always including in the ranging the 1 centimeter tomography, I was always including the reference point. And in the first time that I was doing my imaging, I was picking the place where the tumor had the wider axis. This was in a very early time point, but already the tumors had to be measured macroscopically. So you could be able to see the tumors or it was pointless. So I was putting the animal inside of the chamber and I was looking for the wider place, the wider section of the tumor that in this case, as you can see here, it was 56 millimeters and my reference point was at 55 millimeters. So they were 1 millimeter away. And this was the one for the left tumor and this was the position of the wider section for the right tumor. That was 8 millimeters away. So each time, the next time, I was taking the image of the 1 centimeter, 1.5 centimeter length, and I was finding my spot of reference and moving 1 millimeter down to find exactly the same section on the left, and exactly 3 millimeters down to find exactly the same section on the right. And I was always considering one section, but always the same one anatomically. So now I'm going to give you a little bit of background. This is a previous paper that we published in which we characterized the MCF7 and the MDA vasculatures. So we had two cohorts, one inoculated with MCF7, that is estrogen receptor positive, prolactin receptor positive, and HER2 positive, and MDA MD231, that is a fully differentiated kind of cell line, triple negative, and it's supposed to be very aggressive, much more than MCF7. So we did several rounds of MSOT, and at the end we collect the tissues and do the blood analysis. So by using MSOT, we could see that we were expecting differences, because we knew that the more differentiated MCF7 and the less differentiated MDA, they should have different paracrine activities. So they should be able to generate a completely different vasculature. And we found that, as you will see. So there was no differences in the tumor, talking about total hemoglobin, but we could see that there was a strong difference in oxygen saturation. In fact, tumors raised by MCF7s were showing an oxygen saturation that was no different to the oxygen saturation of normal blood. So these tumors were not hypoxic, at least on blood, when we are talking about blood. Interestingly, it's true that we had a trend towards being more and more hypoxic of MCF7 compared with MDA. MDA were hypoxic as you would expect, and also were drifting between more and less hypoxic during the tumor growth. This hypoxic state was confirmed by immunological markers. Another thing is that when we split in the tumors between rim and core, we saw a decrease in the total hemoglobin. So outside there were more blood vessels than inside, or at least more blood. So in the outer part of the tumor. But again, interestingly, the core of MCF7 tumors was not hypoxic, and this is something relevant because it's assumed that all the tumors are hypoxic in the inside, and this is not at all our result. And MDA was, as it's supposed to be, with less blood vessels in the inside and also more hypoxic in the inside. This had a reason, of course. So when we are analyzing by immunohistochemistry the characteristics of this vasculature, we saw that although MCF7 had more blood vessels, the marked by the CD31, that is a specific marker of endothelial cells, we could see that this a second layer of cells, at least a capillary to be fully functional, had to have a layer of pericytes that are able to sustain the structure of endothelial cells, so they don't open over the pressure of the heartbeat. So when we were looking at how functional those blood vessels were, we saw that MCF7 were doing less blood vessels, but much better built than the MDA231s. Another interesting thing was that while MDA and MCF7 tumors were not very different in terms of how much human VEGF, so VEGF coming from the tumor cells were producing, there was a strong difference in terms of mouse VEGF. So MCF7 were able to call the surrounding cells, the cells from the tumor microenvironment, in order to produce VEGF for them and build more and better blood vessels. Also, another important thing, it was that MDA MB231s, apart from producing new blood vessels, CD31 positive coming from angiogenesis pathways, it was positive for vascular mimicry. So during vascular mimicry, tumor cells transdifferentiate into endothelial cells. And this was confirmed by typical markers of vascular mimicry, such as the cadherin and the combined staining of CD31 and PAS. So based on these two main findings, we move on to the vascular response. So if there were different vasculatures, then probably we had different response to anti-angiogenic therapies. So for that, we designed this experimental plan in which we had, again, two cohorts. We split them in three groups. The intermediate group, that was how was the tumor just before starting the treatment, and then a control group and a treated group, in which we injected bevacizumab weekly. So in the beginning of the experiment, what we could see is that we could confirm the results of the previous set of experiments, in which we could see that the number of blood vessels was higher in the MDA, and again there was a difference in human VEGF production. But also we measure a difference in the amount of fibrosis that was much higher in MCF7 rather than MDA. So they were histologically different and they respond differently. So we had no positive response to treatment in MCF7, so no improvement in survival or in tumor size, and we had a subgroup of responders analogously to what we could see in humans, a subset of responders in the MDA MB231 cohort. So if we focus only from now on, we are mostly going to talk about this cohort, we could see a strong difference in tumor size between, not only in survival, but in tumor size between control, bevacizumab non-responders marked as NR, and responders marked as R. So MSOT wise, we could see no differences between control and treated in MCF7, as there was no difference in response, and we could see a clear difference, especially in oxygen saturation, in the cohort of MDA MB231 that was able to differentiate between control and treated and between non-responders and responders. So first at oxygen saturation levels, but also in terms of total hemoglobin, that interestingly is increased in the responders. But this was a final time point analysis. So we were happy, of course, but we were thinking, okay, but this is not really relevant because, you know, as long as you see if the tumor did grow or didn't grow, then you know if it's responding or not. Especially in preclinical settings, it's quite intuitive, let's say. So we came back and tracked all those imaging sessions that we did before. So the first interesting thing that we did, it was after the first shot of bevacizumab that we gave to the animals, it was IP injection, we saw differences between responders and non-responders. Again, the best performer was oxygen saturation, in which we could see that non-treated animals had a trend to increase the levels of oxygen saturation in both control and non-responders. Both showed a similar kind of trend. And on the other hand, responders showed an almost significant decrease, but clearly a break with the increasing saturation trend showed by non-responders and responders. So this was the first differential point. There were also some differences in terms of total hemoglobin, but they were not as solid as oxygen saturation, in which, as you see, when we keep following the oxygen saturation, we saw a clear change in trend between non-responders, in which oxygen saturation tends to go up, and responders, in which oxygen saturation tends to go down. And we could see this clear trend few weeks after the beginning of the treatment. Those results about oxygen saturation were strongly correlated with hypoxia markers. We monitor hypoxia at two different levels. So first with hypoxyprobe, that would give a readout of the instant hypoxia that you had in the tissue at the moment of the collection of the tissue, and then CA9 and VEF, that both depend on HIF transcription factor activity. And again, as you see, the three of them show the same behavior. So a little bit of increase in hypoxia or hypoxyprobe, but then no difference between control and non-responders, and a clear increase, a significant increase between non-responders and responders, and of course controls. At biochemical levels, and confirming the measurements, the readout that the MSOT total hemoglobin gave, we observed a biochemical increase of hemoglobin that was described previously in the literature. So that was a very nice result. And regarding the target of the bevacizumab, the human VEGF, we saw that the responders were the only ones in which bevacizumab was really successful sequestering the VEGF. So for some mechanism, either overload or others, non-responders had overcome the treatment. When we were looking at the vasculature, we could see that the number of blood vessels in responders was increased, but the number of blood vessels that had smooth muscle actin coverage, indicating the pericyte coverage, was significantly decreased compared, especially with the non-responders. So again, the responders were trying to resist the attack of bevacizumab by producing more blood vessels, but these blood vessels were not functional and were not able to bring more blood into the more oxygenated blood into the tissue. This is also interesting because several times it's assumed that the mechanism by which bevacizumab or other anti-angiogenic factors work is by normalizing the vasculature. So our results indicated totally the opposite. So they were not normalizing the vasculature, they were making more chaotic kind of vasculature that was at the end useless, let's say. So as a summary of our findings, we saw that different degrees of cell differentiation and of estrogen receptor status in breast cancer xenograft models were producing different kind of tumors and different kind of vasculature. One had normal oxygenation levels, blood vessels with pericyte coverage, and the VEF was coming, a lot of VEF was coming from the tumor microenvironment. And the other one, the MDAs and B231s, the estrogen-independent ones, had low oxygenation levels, more blood vessels without pericyte coverage, and the tumor cells are the main source of the VEF. And upon VEF treatment, those ones that had normal oxygenation levels were resistant to treatment and had no readout, no difference in the MSOT readout, either at oxygen saturation or total hemoglobin. But the ones that were sensitive had two different kind of results. So the ones resistant to treatment were more similar to the MCF7s. So had no changes in oxygenation and had better built blood vessels, and that somehow made them more resistant to the therapy. And the ones that were sensitive to treatment were more different to this kind of phenotype. So they showed a decrease in oxygenation, but also had blood vessels without pericyte coverage, so worse built vasculature that was not able to respond to the treatment challenge. And that's all from me. So thank you very much for your attention and your patience. And yes, everything was done in Bondic Lab, Vision Lab, and it is a wonderful place to work and full of wonderful people. So thank you very much to them, because without them this would have been impossible. And thank you very much also to my current group back in Spain. So I'm open to questions.
Brilliant. Thank you very much, Dr. Quiros Gonzalez. That was a great talk. We do have many great questions, so I will start with a few. The first question is, do you think your work could be translated to humans?
We hope so. So actually, ITER has a set for clinical research, and a collaborator of us was using it to characterize differences in different types of breast lesions. So normal breast, and then pre-malignant and malignant. And she was able to see some important differences. So I don't see why, based on those positive results, it won't be translatable into the clinic, because the clinical system it's showing that has similar sensitivity to the preclinical system. The question is if this response that has been seen on mice, it's also happening in humans.
Okay, thank you very much for that. The second question is, your studies require longitudinal imaging. Have you looked at the variability in imaging in control animals over time?
Yes, we did. We had a paper published about this, and it is quite reproducible. So if I recall correctly, we had variation coefficients below 10%, even when we were using different operators. So even when someone is monitoring one mouse, it's monitoring the same mouse 3 days later, and someone comes and monitor one mouse, and someone else is following some advice, it's monitoring the same mouse 3 days later, the results are quite similar. So the variability is, I would say, very good.
Okay, thank you for that answer. I'll ask one more question and then we will conclude this webinar. There will be a few other questions that we follow up on after the session. The final question is, how long does it take to image a mouse using MSOT?
It depends for how long you want to, if you go from nose to tail, it will take a while. You could. In my case, it was a matter of minutes. So it could be 3, it could be 5, 6, usually no more than that.
Okay, thank you for that. And thank you again for your talk, Dr. Isabel Quiros Gonzalez. We really appreciate the great talk and the information you've given us today. And to our audience, we will be in touch over the next few days with the recording of this session. And thank you all very much for your time today. And we'll wrap up the webinar now. And goodbye to all of you.